Okay, so we'll be going live, Dhwani, now. We are in a practice session. We'll start the webinar right now, and then I'll start off and then I'll share the screen when it is required from your side.
Yes, sir.
Yeah, okay. Okay, so good afternoon, everybody, and it's indeed a pleasure to discuss about this very, very important topic which we recently saw. And we have been discussing a lot about hyponatremia over time. And often we talk about and emphasize the need for a careful evaluation and management of hyponatremia, especially if it's chronic. But often we tend to consider that it may not cause too much harm. We'll be discussing about a case which is not an unusual scenario, a common scenario of long-standing hypoparathyroidism. And on treatment of that, and this can often happen with endocrine causes, we'll think, okay, we are treating just the endocrine cause. This sodium fluctuation may not be that much relevant. But how much difference can it be made in terms of inappropriate management can cause confusion from that perspective is something which we'll showcase on this perspective. And we will see how this case scenario caused a lot of confusion and problems in terms of evaluation and management, and how simple measures could improve on that. So this is a very, very interesting situation in which we saw a lot of fluctuations in sodium levels, and those fluctuations caused a lot of problems, and we were able to intervene at the right time to prevent the complications. So this will be an important message also from that perspective in that regards. So before we start off with all these aspects, we will have a quick update, a brief update about what really are we going to talk about and how we could have prevented, and then we'll talk about in terms of the overall aspect of how to prevent these complications from happening and how to manage them appropriately. So we all know that when we talk about tonicity and osmolality, these are two important terms. So osmolality means the number of osmoles which are present in the body. They include the sodium, glucose, and urea. Now, the difference between osmolality and tonicity is that basically sodium and glucose cannot really cross the cell membrane. For sodium to cross, there is already a sodium potassium ATPase. For glucose, you will need insulin. While urea can freely cross. So urea does not contribute to the tonicity of the plasma. So the major determinant of tonicity is sodium and glucose. While if you talk about glucose, the levels are usually normal. So in the absence of hyperglycemia, sodium is the major determinant of our body tone. Now, in conditions like hyponatremia, or in scenarios in which you have a AVP excess, and we discussed that any scenario in which you have got chronic hyponatremia, you will have an excess of arginine vasopressin. In those scenarios, you will have a decreased tonicity of the blood. So the brain cells will basically have a swelling. So they will go into a edematous phase, and that causes all the features: cerebral edema, headache, irritability, seizures, and other problems. Now, to counter that, of course, body does have a mechanism in the form of idiogenic osmoles, which are basically extruded, and through that we are able to save all these problems to happen. There is an adjustment which happens. If there is a rapid rise, however, in the serum sodium, this adjustment becomes maladjustment, and that may cause a problem. And we have been hearing about this since medical school, the term which was earlier known as central pontine myelinolysis, and now we call it more appropriately the osmotic disequilibrium syndrome. So your whole cells will basically, which are swollen, then become normal, will suddenly shrink. So you will have a lot of lysis of these cells, and that causes this myelinolysis. So we'll talk about this is the fundamental aspect which we'll discuss as to how this happened in this case and how we could have prevented, how we could have improved in terms of outcome in that regards. Now, all of you can go and have a look at our website, learning.growsociety.in, which has got a lot of resources related to pediatric endocrinology courses, including fellowship and diploma programs. We routinely run multiple programs in the form of postgraduate lecture series, grand rounds, their publications, as well as the mobile application. So today, we are going to discuss about a very, very interesting case. Dr. Dhwani, who is our fellow, will be discussing about how this case presented and what it looked like, a normal scenario, and how things changed. Then we'll discuss about what went wrong, and Dr. Manoj will talk about the overall reasons that went wrong and how we could have picked it up at an early stage. Then we have got Dr. Santosh, who is visiting us from Trivandrum, who will be talking about how imaging or other diagnostic measures can help it out. Then we will have a discussion as to what are the measures which could have prevented and how we could have treated in this case by Dr. Vibha. And finally, we'll bring everything together to see how this case management could have been better from that perspective. So in that background, we will now start with the presentation, and I'd like to invite Dr. Dhwani. So Dr. Dhwani is not with us currently. Dr. Dhwani is at her hometown. She can present the start the presentation. Dhwani, you are muted at the moment. Yeah.
Good evening, sir. Thank you for the opportunity.
Yeah.
So let us start with the case presentation. We had Mrs. M, who was a 40-year-old female who presented to us with loss of appetite for 20 days, lethargy, weakness more since the last 20 days. On inquiring further, we got this history of stillbirth at 22 years of age with history of secondary amenorrhea since. There was history of decreased interest in activity, lethargy, poor sleep quality for the last 20 years, ever since she had this stillbirth.
So I think that's a very, very important history that you've elicited there, that at 20 years of age, she had a stillbirth, and after that, she had secondary amenorrhea. Now, one question which will really help you out reach a final diagnosis is, what would you ask at this point, which will tell you that this is really the diagnosis you're looking at? First, what diagnosis are you looking at, and what single answer will give you a final diagnosis there?
So if she had lactation failure,
yes,
in the immediate or postpartum hemorrhage, if they give a classical history of having bled a lot, then that will really clinch the diagnosis.
So this is clearly what you think. This is a Sheehan syndrome classical presentation. A patient who actually had a delayed overall problems in terms of the postnatal period. And the key question, as you said, would be to ask whether there was a lactation failure in that scenario. So now you have all these features are suggestive of a classical low level of cortisol deficiency. So let's continue from there.
Yes, so all of her symptoms were attributed to clinical depression, and she was somehow started on antidepressants, which she had been taking for the last 6 months with no significant benefit in symptoms. For these complaints, she had also visited our OPD about 10 days back. Because the symptoms were non-specific, she was advised some blood tests which showed microcytic hypochromic anemia with thrombocytopenia. Her rest of the investigations were predominantly normal. She was sent on some oral supplements. However, as symptoms persisted, she reported to the emergency room 10 days later.
So who was the primary, like which physician did she go into, which specialty in the beginning?
She went to the cardiology department.
Okay, so because of this lethargy, weakness, they went to the cardiology department. Now, again, they have done basic workup, which shows anemia and thrombocytopenia. They have done a TSH as well. What do you think is the thing which you would have done better at that point of time?
It is always necessary to look at the free T4 level in the context of TSH level.
So just doing a TSH, definitely again, second message coming up here that if you just do a TSH, you may miss a lot of problems in that. And the other big message, what was missed here was the serum electrolytes. So routinely, if you have somebody who is lethargic, weakness, you should look for electrolytes as well. Yeah, please carry on.
At presentation to ER, her heart rate was on the lower side at 64 per minute. Respiratory rate was 18 per minute. She had cold peripheries and BP of 70/60. She presented to us in a confused state with slurred speech. However, her sensorium was E4, M5, M6, V5, and pupils were 2 millimeters bilaterally equal reactive to light. She had slightly brisk DTRs with mute planters and blood sugar on the lower side at 66 milligram per deciliter.
So there are two big messages that you are giving. There is bradycardia, which is there, and there is hypoglycemia. So hypoglycemia and bradycardia, what would you think of?
Hypocortisolism is somewhere.
So hypocortisolism means multiple pituitary hormone deficiency, because you have a thyroid probably affected. And of course, we know the diagnosis, so we are more biased. But if you have somebody who has got hypoglycemia with all that presentation and who has bradycardia, we are thinking clearly of a MPHD like this. Yeah, carry on.
So this was the initial lab investigation when she presented to the ER. So again, we had a hemoglobin of 10.5, sodium of 100, and a potassium of 2.9. Rest of the investigations were essentially normal. Again, only TSH was done at ER, which was in the normal range. She had a slightly elevated SGOT level. But the most important or most worrisome thing that I find in the initial lab is her sodium of 100 against a potassium of 2.95 here.
So I think this is a very, very starking report. Now, we normally say when you have hyponatremia, sodium and potassium usually go the opposite way around. So if you have hyponatremia, you will have hyperkalemia. If you have hypernatremia or high normal sodium, potassium will go down. What are the conditions which cause hyponatremia with hypokalemia, Dhwani?
So adrenal insufficiency is something that will cause hyponatremia with hypokalemia.
Adrenal insufficiency in the sense, so if you have primary adrenal insufficiency, we expect to be hyponatremia and hyperkalemia. That will be salt wasting. So generally what we say is that when you have both low, you are losing. So you're losing either from the tubules, diuretic use, or you have a gastrointestinal loss. Now the question is that if you are attributing it to adrenal insufficiency, is it central versus peripheral? What do you think based upon this sodium report?
Central, definitely.
Central, definitely, because the potassium is normal. Now, the extent of sodium reduction is very, very remarkable. So I think that's something which is another thing to really consider, because as we discussed it when we compared three classical scenarios, if we say isolated glucocorticoid deficiency versus isolated mineralocorticoid deficiency versus a combined defect, which one of these has a maximum effect in terms of sodium levels? Which one of them the sodium is the lowest?
The combined one usually.
Yes, because 100 is too low. That is something which I would be a bit too. I have seen hundreds predominantly in adrenal insufficiency, in CAH, that sort of a scenario. This 100 was extraordinarily low. The second thing is that potassium is also low. So normally they have a normal potassium, but of course, if somebody is not eating well, somebody is malnourished, you may have some level of hyponatremia, hypokalemia, which may happen. Can you think of any other thing you have already mentioned in your history that could have affected her sodium levels to be that low? Besides the cortisol deficiency. There is, of course, hypothyroidism also. So that also contributes to deficiency, but this 100, anything else? You gave a history. So that she was on some antidepressants. Now we know that many of these antidepressants do cause SIADH.
SIADH, yes.
Now, if you already have cortisol deficiency, if you already have hypothyroidism, on top of that, there is an antidepressant which is further increasing ABAP. Of course, the sodium can be explained. So this very severe hyponatremia is unusual. Typical sodium that you will see in ACTH deficiency will be like 120, maximum 115. I have not seen anything below that, but this 100 is a very, very remarkable, but may have been given antidepressant which could have affected. Sometimes diuretics are given along with that. So you have to be careful about all that. Drug history becomes important. So now you have got an individual who has got 20-year-old history, a long-standing disease. Suddenly the patient comes to you with a sodium of 100. Now, what do you need to understand here is that this patient has been living with this condition for 20 years. It's not that she is in a life or death situation. That is what is very, very important to understand. So don't be too aggressive. Now, remember, this patient was admitted under cardiology. So had they been admitted under us, we would have been more cautious in terms of rise, but they would have seen 100 and they become a bit that something needs to be done immediately. But they haven't thought that for 20 years, the patient was normal and why suddenly we have to worry so much about that. Carry forward.
So let us look at the approach to hyponatremia. When you have a patient with hyponatremia, the first thing to question is it true hyponatremia? Hyperlipidemia, hyperglycemia, and hyperproteinemia. All these three conditions are associated with pseudo-hyponatremia. So the first step is excluding these three. The next thing to ascertain is whether hyponatremia is due to excess fluid or sodium loss. So once we know it is true hyponatremia, we need to know whether it is because of an excess fluid or sodium loss. In a status of free water excess, patient will usually be U or hypovolemic, whereas those with sodium loss are usually hypovolemic. Uric acid is low in free water excess and high in sodium loss. Similarly, hematocrit is low in free water excess and high in sodium loss. Urine sodium is low in free water excess and high in more than 25 in sodium loss.
So clinically, was she euvolemic or hypovolemic or hypervolemic? Because volume is the most important thing to look at in hyponatremia. What do you think clinically she was?
At presentation, she had good pulses, although her BP initially was recorded as 70/60, but subsequently, after giving a single bolus, she had remained in a euvolemic state
So
despite having this
she was pretty much
hyponatremia.
euvolemic. So she
Euvolemic,
was
yes.
not really hypovolemic. So all the insufficiency part, sodium loss part is lost. Now, when you say euvolemia, actually, if you measure their blood volume, you will find them to be subtle hypervolemia. Now, whenever your volume goes up, what will happen then? Which hormone will get triggered?
Aldosterone, like
No,
no,
volume is up.
yeah, AVP.
ANP, atyl natriuretic peptide. So basically the heart will say my volume is up, I'll push the sodium out. So that also will further contribute to hyponatremia. So you get the point? In that scenario, your fluid volume, you have more amount of free water in the body. That free water increases relative hypervolemia, and that relative hypervolemia triggers ANP that causes sodium loss and you become euvolemic. So when you are saying SIADH or hypothyroidism or ACTH deficiency as euvolemic, they are truly hypervolemic, which have compensated into euvolemic in that scenario. So I think this was very clear, and this patient had a mild anemia. So there was no hemoconcentration definitely. So you're talking about mostly a euvolemic hyponatremia. Next, please.
So after we've seen the fluid status, if it is hypovolemic, we need to rule out congestive heart failure, chronic liver disease, or nephrotic syndrome. In patients with euvolemia, the most important thing is to see free T4 level and cortisol levels. If these are normal, then we're looking at a patient with SIADH.
So one big message is that whenever the intensive care specialists see hyponatremia and patient is not having hyperkalemia, is euvolemic, they label it as SIADH. SIADH is a diagnosis of exclusion. SIADH basically means you have got dilute blood and concentrated urine, opposite of DI, dilute blood, concentrated urine with a normal renal, thyroid and adrenal functions and no history of uptake of diuretics. So all these are confounding factors. So clearly we are out here. Fluid status is euvolemic. You need to do a thyroid profile and a cortisol before you go ahead any further. And we have mentioned FT4. That is again a message that this looks like a central scenario. So please go ahead.
And in hypovolemic patients, one needs to look at the urine sodium. If it is more than 30, if it is less than 30, then we're looking at GI losses. If it is more than 30, then we need to look at the serum potassium level, which if low, we're looking at kibulopathy or diuretic use. And if it is high, we're looking at RAS defect. So we went on to the further investigations and we found that the serum cortisol at 8 a.m. was definitely low. TSH was normal in the background of a low T4 level, and LH-FSH were again in the lower for postmenopausal age.
So now when should you do this cortisol level? Should you do it in the morning?
Because we want to document a low level, we would like to do it at 8 a.m. Like we are expecting a low value. So
suppose somebody has come to you at 10 a.m. You will say, I'll check it at next 8 a.m.
No, we can.
See, this patient is hyponatremic. So if you have hyponatremia, if you have shock, if you have hypoglycemia, already the ACTH is very high. So you don't need to actually wait till 8 a.m. So this is all the cardiology workup that they have done. We would have said immediately get a cortisol level, get the report in an hour, start hydrocon, because we know the diagnosis very, very clearly. So you don't need to wait till 8 a.m. That's a big message. Otherwise, you will be wasting a lot of time in that perspective. So if there is shock, if there is hyponatremia, if there is hypovolemia, if you have got hyponatremia, you should get a cortisol level immediately and that will be fine. Now this 88, Dr. Manoj, what do you think? This 88 is low, but how low is it?
Well, the normal level is 130. And at the higher ACTH level, the background of the high.
So how much should it be? Would you find it to be normal? Yes, so at least it should be 500, 550. So this 88 is very, very low. And what about the thyroid? Clearly, FT4 is pretty low and TSH is less than 20. So this is a classical case of central hypothyroidism. Now, the one point which Dhwani has very nicely pointed out is that LH-FSH was normal. Now, this is a lady who was not having any periods. So not having any hormonal development in LHFSH is normal is inappropriately low. So this is classically a multiple predatory hormone deficiency. Please go ahead.
So in our database, we have a 42-year-old female presenting with secondary amenorrhea after a stillbirth with progressive lethargy since then. On examination, in a predominantly euvolemic state with subtle features of raised intracranial pressure, and on investigation showing hypoglycemia, hyponatremia, hypokalemia with central hypothyroidism, cortisol deficiency, and low LHFSH. So we pretty much have the picture. This is hypopituitarism secondary to Sheehan syndrome.
So now, just before you go ahead, now, how would you classify the severity of hyponatremia? Is it acute, severe, acute, moderate, or this is chronic hyponatremia? How will you classify?
This is definitely chronic hyponatremia.
And definitely anything which is beyond 48 hours, we call it chronic. And here the history is so long. So this is of course chronic. And if you don't know the history duration, you assume it to be chronic. I think that's the key message when we are starting treatment again becomes important. Please go ahead.
So management of hyponatremia based on symptoms, it could be acute, severe, where the sodium level is usually less than 120. Here you give 3 to 5 ml per kg, 3% saline bolus until symptomatic, and you target a rise in serum sodium of not more than 12 millimoles per liter per day. Acute moderate is sodium between 120 to 130. In this condition, you avoid bolus and you target a rise in sodium of 6 to 9 millimoles per liter per day. And then comes the chronic variety where no acute treatment is needed and you target a rise in serum sodium of not more than 6 millimoles per liter per day.
So this looks like the chronic state. But if you have subtle features of CNS involvement, like you were saying, brisk reflexes, raised DCTRs, you may consider a low dose 3% saline in that category of chronic as well. But again, low dose, not like a high dose. Now, what actually happened from the cardiology perspective? What did they do?
Yeah, and while it is important to target a rise in serum sodium, you must always even treat the underlying etiology in these cases.
Yeah.
So what happened in the index case was, for hypokalemia, her ECG was normal and she was started on potassium supplement. For hypotension, she received an initial bolus, following which she remained euvolemic and was well otherwise. On the hyponatremia front, she was given 3% saline bolus followed by infusion along with aldactone.
So what do you think? How do you assess this? So of course, she was given 3% bolus, which we may consider okay, but 3% infusion clearly is a problematic issue. How much sodium increases with every 1 ml per kg per 1 ml per hour of sodium infusion, 3% saline infusion? So 1 ml per kg per hour of infusion, how much sodium will increase by that?
I'm not aware of
roughly 1 millimoles. So she was, I think, on 50 or 25. How much she was on per hour?
25 ml per hour.
25 ml per hour. So she was like 0.5 millimoles per ml per kg per hour. That would have rose by at least 12 in a day. So that was going to in a very, very wrong trajectory. We don't want it to go beyond 6 or 8. Now, aldactone. Now, what would aldactone do? Vibha.
Basically,
Yeah. Vibha, what will aldactone do? No, it antagonizes what? It is against what? It is a mineralocorticoid receptor antagonist. So your glucocorticoid is already not there, and then you are also blocking the mineralocorticoid, not the RAS, mineralocorticoid receptor. So your glucocorticoid is already not there. If you're going to block your mineralocorticoid, you're going to cause hyperkalemia and you're going to worsen your hyponatremia. So probably this is a bit preposterous to say, but probably aldactone did not allow the sodium to rise that much as it would have risen had they not given aldactone. So it might have been pulling it down. So it was so both are inappropriate, but this could have balanced it out because this could have not allowed sodium to go up that quickly. But that definitely is no physiological basis of either of those treatments. Yes, Dhwani.
So what happened was, with this treatment, serum sodium rose rapidly from 100 at presentation to 122 within 36 hours of hospital stay. It was at 36 hours of hospital stay that finally an endocrine call was given when 3% saline and aldactone were finally stopped and the patient was started on injection hydrocortisone.
So by the time this is a very good graph. You can continue. Yeah.
So this, as you see, the serum sodium had risen from 100 to a very rapid rise of 122 at 36 hours of hospital stay. And why associated with this rise in serum sodium, we found the patient to have a clinical worsening in form of meaningless muttering, a start of chorioathetoid movement, worsening of slurring of speech. She was unable to sit up straight and was constantly rocking in her bed. There were intermittent episodes of vacant stare with drooling of saliva from the angle of mouth.
I think that's very important to remember and understand that many of these patients have been so sick for such a long time. Nobody knows what their normal state is. Some people say they are like this. ये तो ऐसे ही थे शुरू से. So these signs you have to be very, very careful. So when we saw this patient at 36 hours, already the sodium was 122 to 124. We said, okay, no further rise at this point of time. And we were looking for all those things. There were some subtle features, but by next day morning, I think probably another 24 hours passed when all this night sleep abnormalities, continuously fidgetiness, abnormal movement, and subtle signs started to creep up. So this is something which, if we had picked up even earlier, that would have been better. But again, they are very, very subtle and often difficult to pick up. Yeah, carry forward from there. So I think...
yeah, I'll just stop sharing.
So I think this is what has happened. Now, how do we go forward from here? So we clearly have a scenario in which the sodium was very low to begin with, and then subsequently there is a sudden rise. And what we are seeing probably around 36 or 60 hours, that there are certain signs which are happening. Now, first of all, we need to know what these signs are and why are they caused. So we will start off basically with regards to our discussion about what this probably looks like and how do we go forward in terms of further evaluation, how do we make the diagnosis. So I'll invite now Dr. Manoj, who will be talking about what really is going wrong in that perspective and how we could identify this problem immediately. So Dr. Manoj.
So thank you, sir. So it was very nice case presented by my colleague, Dr. Dhwani. So now she has mentioned very nice clinical features that patient has suffered. So now looking into the topic, what is the osmotic disequilibrium syndrome? So in this defect, mainly brain is affected. And what are the part of the brain mainly affected? That is the brainstem. And what is the importance of the brainstem? Brainstem has the pons, midbrain, and thalamus. And pons is very important point. It conveys the all message from the peripheral to the central region. It takes all the sensory and motor sensation and it convey to the cerebrum. So if pons and the peripheral pons tissue is affected, then we have some kind of spatial symptoms that we will see in this topic. So in osmotic disequilibrium syndrome, there is a both chances, pontine and extrapontine involvement will be there, and symptoms are different for the both. So what is the really central pontine myelinosis? So it is the involvement of the central nervous system which cause the pontine and the extrapontine involvement, and this occurs typically due to the osmotic changes. It is not due to the inflammation or it is not due to the infection. So here the dehydration caused the myelin sheath breakage and it's caused this typical symptom. So if we see, then this patient have some lucid interval. So in the beginning, our patient was asymptomatic. We were happy that patient was recovering. And after this, some 1 to 2 days, usually patient worsening will be there in terms of the 48 and 72 hours. And there will be, if we don't treat at the particular time, that patient may have the gradual progression which cause the coma and death. So what are the functions of the pons? Pons is a major part of the brain which links the brain with the spinal cord. And it have the major two pathways that we are discussing mainly. One is the corticobulbar pathway which take the information from the periphery to the brain. And why it is important? Because it regulates the muscle movement of the face, neck, and the speech. So if this corticobulbar pathway is affected, then our speech will be difficult, our facial movement will be affected. And second part is the corticospinal pathway. Why it is important? Because it conveys the all information from the brain to the motor tissue. So if this pathway is affected, then we have the extrapyramidal symptoms like Parkinsonism. So firstly, in all osmotic disequilibrium syndrome, corticobulbar pathway involved, and if we don't treat, then there will be the involvement of the corticospinal pathway. So what are the main function of the pons? It regulates our sleep cycle. It regulates our pain signal. It regulates our movement and the balance. And fourth is it regulates our respiration. So if pons is affected, then in this case, what are the main symptoms? Patient may develop the altered sleep cycle followed by the dysarthria with the decreased pain sensation. And if we don't treat, then involvement of the corticospinal and bulbar tract will be there, and it causes the dysarthria, dysphagia, facial paralysis, loss of the balance, coordination, and finally quadriparesis. And finally, there is a state of the locked in state that where patient can't able to it is in locked in condition. So
patient will basically be looking at one side. You will feel that there is a sensory, but they are not responding. Yeah. And they're not behaving. So I think most important point which you have said is the sleep cycle. So always when you have this sort of cases, ask them to a good history whether they have been able to sleep or not, or whether they had a very disturbed sleep. That is there. The second thing, of course, is the abnormal movement that they are within sort of movement which appear, which is a bad sign at that point in this area. So speech, movements, and sleep. These three will be the major things to look at.
And finally, if we don't treat this patient at the right time, then it may end up with the arrest, coma, and death due to the respiratory center failure. So in our patient, firstly, as sir greatly explained that will be the altered sleep pattern. So in this patient, sister has given typical history. There रात से सोई नहीं है. Like there was a typical history of altered sleep cycle, and there was a dysarthria followed by. So in our previous case also, there was a similar history. There was the altered sleep pattern and dysarthria was there. And finally, our patient has some another moments. So we will discuss it later. So what are the etiology for the development of the osmotic disequilibrium syndrome? So as sir told, any cause of the rapid correction of the chronic hyponatremia. Hypokalemia also can cause the osmotic disequilibrium syndrome. So what are the causes?
If you have associated hypokalemia, they tend to do
worse. Yes.
And this is the point which is important. In this case also we had hypokalemia.
Yeah. So what are the causes of the chronic hyponatremia? So if we compare about the adult and adolescent age, then chronic alcoholism, chronic liver disease, and malnutrition was the biggest factor that has been reported till date. So in our patient, there was a malnutrition was there and hypokalemia was there. So it was a triggering ODS. And if the patient has a multiple pituitary hormone deficiency, in the diabetic ketoacidosis, and if patient went into the dialysis, that caused the ODS to develop. So in our patient, there was the MPHD was there, Sihan syndrome, malnutrition was there, hyponatremia was there, and hypokalemia was there. So it was C has high chance of the development of the ODS at that time. So according to case reports, what I likes to highlight, in the diabetic ketoacidosis, generally cerebral edema and hyponatremia occurred. But this case has been reported in the USA, and where the cerebral edema was treated, there was a bicarbonate induced cerebral edema, and in that case they gave rapid correction and they developed with the ODS.
So this is a very important message. In cerebral edema, what is happening in diabetes, you have actually the hyperosmolality. Hyperosmolality, rapid correction causing cerebral edema. Now, if we become too aggressive and treat cerebral edema aggressively, we can again go into the same scenario. We are doing the same thing. We can cause a shrinkage. So we should be preventing both the not treating too much diabetes, not treating too much cerebral edema. So a lot of people we have seen now is that if there are no clinical objective use of cerebral edema, there is a child is looking sick, he must have cerebral edema, let's give the manager. that also should be avoided. So you need to be very, very careful that you have got specific criteria. Use criteria is followed and don't be too aggressive. So what happened here, that first the patient was having a shrinkage. Then because the treatment became edema and then again shrinkage. So this of course will be a very, very bad scenario.
So important message from this case report was that if you if you give unnecessary fluid, if we correct the cerebral edema inappropriately, then it can cause the ODS. So patient may have some complication. So finally, if we discuss about what are the symptoms that the central pontile myelinosis, as we discussed, a patient initially may become asymptomatic. So there could be the lucid interval. So in that time, if we have the risk factor, then we have to be worried. We have to keep watch on the sleep cycle and the specifically of the dysarthria, because if we don't keep watch on these symptoms, then patient may have some another symptoms. So patient may have asymptomatic clinical stable interval followed by the ODS induced deterioration, which takes 1 to 4 days, and followed by encephalopathy, loss of memory, dysarthria, dysphagia, and altered sleep pattern. If we don't treat at the right time, then patient will end up with the placid and the spastic paralysis, followed by lock-in syndrome and the death. These are the symptoms if the pons is involved. But nowadays, because of the MRI is easily available, so in the literature, they found that there will be the extrapontile association is also there. So which affect the mainly extrapyramidal symptom, which affect the mainly movement and the balance. So in this patient, the dystonia, myoclonus, rigor, and the atypical movement we can find. And finally, it can cause the ataxia.
I think this is important because when we discussed with the neurologist,
Yes.
when we were thinking of what can be done, we were thinking how bad is the situation, whether it will improve or not. So he said this looks more like an extra pontine rather than central pontine, which gives us a way to go more aggressive in terms of treatment.
So if we compare both the symptoms, then they both have some general symptoms, which is encephalopathy, seizure, mutism, apathy, and lethargy. If we compare about the cerebral pontile myelinosis, then the locked-in stage, dysarthria, dysphagia, and the coma will be the prominent symptoms. And the in the case of the extrapontile myelinosis, tremor, dystonia, chorea, myoclonus, and movement disorder will come place. So in our patient, we have found some choreoathetosis, and some tremor was there. Mainly movement was affected mostly. So as sir rightly told, our patient had an extrapontile myelinosis. So in our patient, there was an involvement of the extrapontile involvement. So whenever patients come with this kind of symptom, then initially why we have to take care, because initially we have to rely on the clinical diagnosis. If that time if we do MRI or CT scan, then it could be negative. So we don't have to rely on the MRI and the CT scan on the initial basis. We have to diagnose the patient on the clinical basis, and it is important because if we take appropriate therapy for that time period, then we can survive the patient. So according to literature, most ODS reported has been in India is reported by the hyponatremia, followed by the hypokalemia. If there is a hyponatremia and hypokalemia is there, then chances of the ODS will be more. And what are the initial symptoms that we generally see? Generally, we see encephalopathy at the presentation and the seizure, and followed by some extrapyramidal symptoms if extrapontile myelinosis is there. So nowadays, because of the easily availability of the MRI, the central extrapontile myelinosis is coming more than the pontile myelinosis. So that for that part we have to take care. So this is.
So I think this was very, very nicely summarized by Dr. Manoj, who really emphasized about what symptoms to look at and how to look at extrapyramidal symptoms, which will be very, very easy to identify from there. So now the second issue is, of course, about how do we confirm the diagnosis. So we have got Dr. Santosh, and we are really honored to have him. He is currently with us for the last week or so. He is from Associate Professor at the SAT Medical College, Trivandrum in Kerala. And Dr. Santosh, please, you can highlight about the diagnosis. So this is the forward question.
Thank you, sir. Thanks, Dr. Manoj. So most of my job has been already done by Manoj, because the these clinical features tells about to how when we have to think about this ODS. So first of all, as a clinician, what we think is that when a patient is in ICU or coming out of ICU, suddenly new bizarre CNS symptoms arises. We should, if even though we don't know whether there is a sodium correction, but still we should suspect it. And then immediately, if this patient had a sodium around 110 only, but the correction was over by 36. According to our protocol, that correction should have taken more than 4 days. Actually, each day around 6 to 8 only we have to correct. If you take it 6 days, almost it take around 4 days. From that itself, we know that even though by the days in the hospital stay or how many days the correction was there, we come to know it is, we have to suspect ODS. And seeing the trajectory of the sodium and timeline, so sodium and time axis, we can make out how the slope was, whether it is a very steep slope or whether the slope was very low. From that itself, we can make out. And with 120 sodium, usually we are correcting with sodium. Usually it should not be, if it's correct increase, you don't expect a linear rise in sodium. There should be some zigzagging, like Sir had put this seesaw appearance, a blade of seesaw. Usually it will ups and downs. Like that it should be, usually we expect in that. So I visualize this like a adventurous ant. The trajectory of the sodium rise should be an adventurous ant crawling on a seesaw blade, raw edges of the seesaw blade. That way it should rise. Ups and downs should be there. Okay. So the history and clinical features guides towards the diagnosis. There is so by clinical features we can diagnose, but there are always a limitation in neuroimaging. One is that the findings, the lesion findings will be very late in imaging, and second is that in CT scan we don't get much finding. We have to depend upon MRI, and the clinical features predict the course and prognosis. In that also the neuroimaging lag behind. So always the clinical manifestation is important, and then you have to go for neuroimaging for confirming it. So CT scan is less sensitive than MRI, and we have to, as the name implies, this is otherwise known as central. The term is ODS. Earlier it was CPM, central pontine myelinosis. So from the term itself, you have to just see the points in MRI. That's all. Your diagnosis is done. Just see the central part of pons, central pontine myelinosis. So if you see the central, and if it is a T2 weighted imaging, you just look at the central part. And this is a CT. You can see a hypointense lesion in the central part of the pons. The diagnosis is done. So if it is a T2 weighted image, you just see the central part. You can see a hyperintense signals there. So it is suggestive of ODS. And this is fluoride deoxyglucose imaging, in which this myelinosis part will be hypermetabolic, and it takes we will get the signals here, and the rest of the brain looks normal. So that is the imaging. Just see the central parts. This is the okay. Yeah, here you can see in the pons, you can see a trident sign. That is like the Trishul. Trishul we see. I can point out. Here you can see the Trishul-like sign. That is actually the name comes from the Greek mythology, with a spear with three-pronged end, like that. This is the classical sign and a gold standard in MRI diagnosis.
So I think that's very well. Because the other thing, Dr. Pankaj, you said that there is a gap between that. So what is the typical time lag in which the MRI changes appear?
Yeah, sir, it is around 4 to 7 days. Its time lag is.
Now, the other big message, as per celebrity demand, we say do not wait for an imaging.
Yeah,
treat immediately.
immediately,
If
correct.
you are suspecting ODS based upon clinical features, if you wait till 7 days,
Oh.
it will be too late.
Oh.
So this is more of a confirmatory one.
Oh.
But if you are suspecting, then treatment and preventive measures will be
Yeah.
This is very nicely described and find it very, very clear from that perspective.
For early diagnosis, we have to depend on diffuse weighted images.
Yes.
With that, we can early make within 24 hours. We can make that.
But even
that
if it is normal, you cannot exclude.
Yes.
So I think what we need to understand is why are we doing MRI?
Yeah.
If you want to exclude ODS, you cannot exclude ODS.
Yeah.
If it is present,
Yes.
it is there, but it is absent, it can
Yes,
still be ODS.
correct.
So don't. So that's why we should give less importance
So,
to
MRI.
That's why this patient had got MRI earlier, but then we said, okay, now we will not do the MRI.
Okay, thank you.
Thank you.
Thank you.
Thank you, Dr. Santosh, for a wonderful discussion. So we have seen how this patient who was otherwise doing fine had all these problems. There is one question, we'll see if that's there. So that's a typical question. Dr. Bharani is also asking the same. How much time will it take for changes in MRI to happen? Again, up to around 7 days. So don't wait for the MRI. I think that's an important message from that perspective. Now we have already got this problem which has happened. Now what do we do? Whether we could have prevented this problem, how would we manage from here? I think these questions are the most important as well now. So Dr. Vibha will talk about how do we manage both primary, secondary and tertiary prevention.
Thank you, sir. Good afternoon, everyone. After knowing a lot about the clinical features and how to diagnose the ODS, let's move on to the management and the prevention part. It is always better to prevent the occurrence of the ODS rather than treating the established ODS, because the prevention is always better than the cure. But now the question is when and how to prevent the ODS. So this is the normal pattern of the sodium rise that we commonly seen if the sodium hyponatremia is rapidly corrected. And the same pattern was observed in our patient also. She came with a sodium of 100, and after 48 hours, it rise up to the 126. So the question arises, could we really prevent it? Could we really prevent ODS? The answer is yes. We can really prevent ODS. We can prevent it really from the beginning by following the proactive strategy. The proactive strategy is really recommended in the presence of some risk factors, and the risk factors are when the initial sodium is less than 105, when there is a hypokalemia, when there is a malnourished patient, and when there is a history, when there is a chronic hyponatremia, and all the risk factors were present in our patient. So now, if we miss this chance, is there any other option that we can further prevent the occurrence of ODS? Yes, we can prevent it even after the 24 hours of rise in sodium by following the reactive strategy. Even after the 24 hours, if the sodium has increased greater than 8 milligrams per hour in 24 hours, we can still have the chance to prevent the ODS by following this strategy. I will discuss each strategy later on. Now, if we have missed this proactive strategy and this reactive strategy time period, then what can we do? Do we still have the chance? Yes, we can still treat and prevent the ODS. We can follow the rescue strategy.
So we are already at this stage.
Yeah.
The sodium is 124.
124.
And we already missed the 4. So as we were saying, 8. So 6 is ideal, but up to 8 is okay. So here in 36 hours, we already risen by around 15 to 16 per day. So
yes, sir.
Rise. So we are now looking at
rescue strategy.
For proactive.
Proactive.
That message is very important. But if your serum sodium is very low, it is chronic, there is hyponatremia, there is malnourished, you have to be doubly cautious in being very, very slow in terms of rise. That's a proactive one. Yeah.
So rescue strategy is basically for the established ODS, and when the sodium is rising greater than 16 milliequivalent per hour in 48 hours, that was present in our patient. So let's see what the proactive strategy is. It is basically a primary prevention, and it is mostly helpful in the reversible causes when the hyponatremia is due to the when the causes are due to the drugs causing SIDH, when there is a use of thiazide drugs, and when they are suddenly withdrawn, they causes the hyponatremia. And
the other good thing which happened in this case was that hydrocortisone was not started. If
Yes,
we
sir.
had there already started hydrocortisone, made the diagnosis at the right time, it would have really bumped up. That would have been a big disaster.
Yes, sir. And
as Manoj was saying, that probably these patients are better managed in an outpatient basis than an inpatient. Because if you see 100 or sodium of 100, you become scared in the inpatient. But outpatient, you start hydrocortisone, it will be much better. So the good part was that it was delayed. They had given 3%, but they had not given hydrocodone. They had given basically spironolactone, which was bringing the sodium further down.
Yes. And in the presence of risk factors also. So ideally in our patient, we should go for the proactive strategy. If we cautiously manage the patient who has the risk factors like malnutrition, hyperkalemia, sodium less than 105, we can prevent the ODS right from the beginning. And how do we do it? We administer the desmopressin either IV or subcutaneous, 1 to 2 microgram every 6 to 8 hourly. But here in our patient, we preferred 0.1 microgram orally because it has to be given 12 hourly.
So I think this is a very, many people will get confused that we already have hyponatremia. Why are you giving ABP? So this is in a way, you are putting a brake. Your car is accelerating, but you already have a brake so that it doesn't have uncontrolled. Yes, sir. That sort of a thing is important here.
Along with the slow infusion of 3% of hypotonic saline with 15 to 30 ml. Oh, sorry, it's not visible. Now, there is a study showing that the neurological sequelae after the treatment of severe hyponatremia does not depend on the age, sex, alcoholism, and the initial presenting symptoms, and they really depend on the rate of the correction in the 24 hours and the 48 hours. And the risk factors have already been discussed. And this is a
chronic hyponatremia,
malnourished.
Hypothyroidism.
These are the structures.
Which you worry about, and which all are patients.
Yes, sir.
They have chronic, they will be malnourished, they will have hypothyroidism as well. So that is something which you have to worry about. In this case, already had an antidepressant.
Yes,
that
sir.
would also have been stopped.
Reversible
so
cause was present. Yes, sir. And this study was published in AJKD, which clearly showed that during the correction of hyponatremia, we should use hypotonic saline along with desmopressin, because it will not cause the rapid correction of the sodium. The sodium will be rise in the first 24 hours with 5.8 milliequivalent per liter, and in the next 24 hours with only 4.5 milliequivalent per liter. So it is always judicious to use hypotonic saline along with the desmopressin in the correction of the chronic hyponatremia, not only the hypotonic saline. So the mistake that has been done was the usage of 3% hypotonic saline.
So this is like you have a horse, you also have got a rein. You are controlling the horse's cheek rapidly by using a mineral or a
right. So there are the hyponatremia management guidelines from the American and the European Society. The American Society says if there are severe symptoms, give an infusion of 10 minutes of 100 ml 3% hypotonic saline bolus. You can repeat it 3 times if required. While the European Society says give only 2 bolus of 3% hypotonic salines of 150 ml over 20 minutes. They are giving for the longer duration, and for the mild to moderate, give 0.5 to 2 ml per kg per hour 3% saline to correct only 4 to 6 milliequivalent per liter rise in the sodium.
That's the biggest message. First
yes,
big message probably in this case was that this patient was asymptomatic or mildly symptomatic. So maybe even milder correction was not required. When we say acute severe hyponatremia, we're talking about seizures, we're talking about cerebral edema, we're talking about impending coli. This patient had nothing. So probably maximum we could have given something
0.5
ml over 20 minutes and wait for some time and see from there. Giving 25 ml continuous infusion for 48 hours, 36 hours was clearly something which was not required.
While the European Society says on the presence of moderate system, only single bolus is sufficient of 150 ml of 3% NS over 20 minutes. And for the higher risk patients, 4 to 6 milliequivalent rise in the sodium should be the daily goal. And for the lower risk patients, 4 to 8 milliequivalent per liter should be the goal. While the European says the correction of 10 milliequivalent per liter on the first day and 8 milliequivalent per liter daily thereafter. So now coming to the reactive strategy, when we should go for this strategy, when the trajectory of the sodium level is really worrisome, when the correction appears to exceed 8 milliequivalent per liter 24 hours or 16 milliequivalent per liter in the 48 hours. Why does it happen? It is basically due to the water diuresis when the reversible causes like the drugs causing the SIDH, SSRIs, carbamazepine, thiazides are removed.
Or you're treating with hydrocodone.
We are glucocorticoids are given in MPDS.
I've seen CAH who were like 196, they become 120 very quickly, but that's acute hyponatremia. Remember that they didn't have any problem. So once you give hydrocod, they can suddenly go up in that chance.
So
also, if we have started injection hydrocortisone, then also it has rapidly come out.
Yes, so we have to be cautious. In the other case, we had given no 3% saline.
no, sir.
But we had only given hydrocortisone and thyroxine together. Thyroxine deficiency would not have allowed that high level. But if you give both, that would have caused problem.
And we decrease the dose of hydrocod also in this patient. And what we have to do, we have to give the desmopressin either IV, subcutaneous or orally. And if the sodium level decreases very soon, we can add the slow infusion of 3% saline, 10 to 30 ml per hour. And what we have to do, first give 1 dose of desmopressin and then see the sodium levels. If they are increasing very rapidly or the urine output increases, then we have to give the second dose of desmopressin. It is not 12 hourly or 6 hourly. And we have to monitor the serum sodium 2 to 3 hourly. So here's a case report showing the use of desmopressin in lowering the rate of sodium. So if we have a patient here in which we are seeing the rate of correction is going above greater than 16 or greater than 8, we can use the desmopressin. And in this, they have shown that after the use of desmopressin, the rate of sodium correction has gone from 0.58 to 0.15 per hour.
So this was the, as you said, the trajectory from up is going on it has become much more smoother. So I think the principle is that next time you see anybody whose sodium is below 110 or 105, you have to think of adding desmopressin. I think that's the big message which is coming.
Now coming to the rescue strategy.
Okay,
So one of this thing about the desmopressin is that here when we correct this thing, reversible ADH secretion will be there, so that the more of water diuresis will be here. So it adds up to the sodium. So by giving desmopressin, they are closing that tap itself. Then we can titrate this.
I think that's a very important point.
Yes. Now coming to the rescue strategy.
So as we said, that chronic hyponatremia to be there, you will have an ABP issue. Now, once that issue is out, suppose you have given hydrocod, ABP will come down.
Yes, sir.
So that will cause again water diuresis. So if you from outside, that will factor this here.
This rescue strategy really rescues the patient from the death, and it is recommended when the sodium rises greater than 18 milliequivalent per hour per liter in 48 hours, and where there is already established ODS. The same scenario happens in our patient. And what we have to do, we have to stop the water diuresis by the desmopressin, and we have to reload the serum sodium by giving free water. And the same strategy has been followed by us in treating this patient. What we do, we give the 5%.
One of course is free water.
Yes, sir. We gave this 6 ml per kg of IV fluid over 2 hours. Then we measure the serum sodium every 2 hourly, and then we decide the next dose of the free water dextrose. We give the desmopressin orally in this patient, 0.1 milligram 12 hourly, and it is continued even after when the dextrose 5 was stopped to prevent the serum sodium from rising again. And here our goal was to that not to decrease the serum sodium more than 8 milligram per liter in 24 hours.
Aim was that we started at
100.
She will go to around 160.
160.
That's part of a goal and wanted to bring her back to as close as 116 as possible. Now, what could be the problem of giving dextrose in this scenario? You're giving free water
Only.
Decrease the sodium. What problem can happen with dextrose in this patient who is having another problem, another electrolyte problem?
Insulin, right? We are also supplemented potassium in this patient. And we have also added thiamine to prevent the wernicke's encephalopathy because the patient was malnourished. And we also supplemented potassium, as Sir has already discussed, because the infusion of dextrose will trigger insulin and it will call hypoglycemia. And monitor sodium and potassium 2 to 3 hourly and urine output hourly. So we have seen that desmopressin has been used in the proactive strategy, in the reactive strategy, and in the rescue strategy. So in which strategy it works in the maximum capacity? So this is the report clearly showing that if desmopressin is used in the proactive strategy, along with the hypotonic saline, it shows there is a lower incidence of exceeding serum sodium concentration. And it has shown that the rapid correction is very less if we have used desmopressin in the proactive strategies. Now coming
to the usual outcome did they mention about the rescue strategy? Like how many survive?
Sir, this was it actually.
We'll talk about that later.
Sir, about the desmopressin or there?
The overall rescue. So suppose you have established ODS.
There is in the next system. So there are some investigational studies that has been done in the mice. What they have done after the rapid correction of the, they have after the rapid correction of the hyponatremia, they have infused myo-inositol in the mice to prevent the ODS. And what they have seen that after the infusion of myo-inositol, the rat survives. So this is the protective effect of the myo-inositol. This is just the experimental therapy. And another study have shown that there is some protective effect of dexamethasone on the osmotic induced demyelination in rat. They have corrected the hyponatremia rapidly by bolus of hypotonic saline.
More like a
saline. Yes, sir. And they have given dexamethasone to one group of mice and not given to another group of mice. And what they have seen, the mice with the dexamethasone exhibited minimal neurological impairment. So now coming to the established ODS, we follow rescue therapy for the 48 hours in these patients, and there is really a poor prognosis, but we have to follow this therapy. We aim to relower the serum sodium to a level that is just below the maximum 48-hour target value. That is less than, as Sir has discussed, it should be less than 60 milligrams per liter above the initial serum sodium. And the potential efficacy of relowering the sodium after the onset of neurological symptoms of ODS was first demonstrated in the rat model. And for the supportive therapy to prevent aspiration pneumonia and respiratory failure, we should surely go for the ventilator support. And the plasma pheresis therapies is only the experimental therapies. Now, there are some studies on the neurological outcome, as you were asking for. What happened after the relowering of the serum sodium in the patient after the established ODS. So this was the study in which they have clearly mentioned that after the neurological status deteriorated after 72 hours, they do rapid reinduction of the hyponatremia and administration of hypertonic salines combined with the DDAP. They produce the rapid prompt decline in the serum sodium. Yes, sir. And it was well tolerated without any untoward effects, without any neurological sequelae. There is another case report which clearly has the similar lizard, which they also use this 5% dextrose along with the desmopressin, and they have shown that there was no any neurological sequelae As you can see, there was no neurological sequelae after the treatment. And this is the study that was very similar to our patient. Patient was the case of the MPHD, and he was given hormonal replacement. He developed hyponatremia. He had even had quadriparesis, and then they relowered the sodium after giving the desmopressin and this 5% dextrose, and what they have observed, full neurological recovery after 48 hours. So what we have to think, we should always look for the risk factors. We should take careful history of the drugs. We should go for the minor subtle neurological features like the dysarthria, sleep examination. We should take the history of sleep cycles. And we should always go for the slow correction. We should use desmopressin with 3% hypertonic saline in case of hyponatremia. And when there is established ODS, relower sodium, try to save the patient. We should not lose our hope. Thank you.
So I think the big message from all this is that definitely we should go for a proactive and a reactive strategy, but always remember that even if we are late, we can still rescue it. We saw in our case and so many other cases. So don't lose heart. If you see any first sign, start relowering. Otherwise, we should have given desmopressin right at the beginning. So how do we manage hyponatremia? Look at duration and symptoms. If you have an acute hyponatremia, which is less than 48 hours and symptoms are severe, which basically you have to give and sodium is less than 120, then you can give a bit of 3% saline, correct, around 9 to 12. If it's mild to moderate and sodium is 120 to 130, then you rise very small dose of 3% saline. And then rise should not be more than 6 to 8. And above 48 hours, or if it is unknown, you assume it to be chronic. In this scenario, if there are severe symptoms, you may give an initial correction, but then don't try to build it up too rapidly. And if it's mild to moderate, definitely no symptoms and no 3% saline is required in that perspective. So probably this patient was here in that regard. So we could have either tried to give one bolus and go from there. If we are giving correction, we should have added desmopressin also in that perspective. So as we discussed that we want the trajectory to be somewhere like this. But if you have a very rapid rise, suppose somebody is given a Vapten or somebody is given hydrocortisone, somebody has stopped treatment, thyroid, suddenly your sodium goes up. Then in that case, altered sensorium, you give DDAVP and free water, that will bring it down to normal. So this is the salvage therapy, which is there. So now again, we have already discussed in this case how there was problems in there. So Dr. Dhwani, you are there?
Yes, sir.
So what really do you think should have been done here?
So while we should have given DDAVP along with 3% saline at the very outset itself, we definitely got late. After starting injection hydrocortisone, she had shown slight improvement initially, and then we got this history of altered sleep cycle and dysarthria. So that is when ODS had actually set in this patient. And we went for the rescue therapy in form of free water and oral desmopressin. But even with this, we were able to achieve 5 milliequivalent per liter per day fall over 48 hours and a clinical resolution in symptoms.
So that's the key message, that even if you are late, you may get a very good response. So we were able to lower using oral desmopressin and free water. So we gave multiple boluses, Manoj. How many times did we have to give bolus? I think we gave 4 or 5. 5 boluses of 5% dextrose, and to the ICU team, it was looking paradoxical as to what we are doing. Why are we lowering a sodium of 122? But they were not understanding that. But finally, this patient, within a day, we were able to get back out of the ICU. And latest she came to us, she was walking actually. So this is a very, very good, in which the entire team had to work so hard, but it gives a very big messages to everybody. So I think this basically means that when you have somebody with severe hyponatremia, if you are thinking of good correction, rapid correction, give DDAVP at that point of time. Second, if your rise, as Vibha was saying, is more than 8 per 24 hours, give DDAVP then. If you have lost all that, even then if you give free water, if you give DDAVP, you will have a good improvement, which is there. So I think this was a big message with that regard. So this was in the background of she had. Now she is on hydrocortisone, thyroxine, and we deferred the induction of thyroxine. And we reduced the dose of hydrocortisone because we knew that if we give too much hydrocort, if we start thyroxine, the patient will have a sudden worsening because sodium will go really high. And gradually the replacement was done in that perspective, in that regard. So this was the trend which we saw, and gradually after all that we were able to establish. So I think I'd like to thank all of you who were there, who are part of the managing team, Dr. Manoj, Dr. Dhwani, Dr. Vibha, and Dr. Santosh, who has presented so nicely. All of you can go and have a look at our website and our courses and the mobile application. We do have a calculator for hyponatremia fluid calculation, which guides you how much fluid is to be given, whether you really need to give a fluid or not in that scenario, how much 3% is to be given or not. We'll see if there are any questions there. So when monitoring 2 hourly, can we use blood gas, sodium to monitor sodium level? As sodium may take a long time. It depends upon the reliability and validity of the particular tool that you're using. So in my experience, the blood gas analyzers are not good, but there are certain ICU-based electrolyte analyzers which are pretty better in that regard. So you don't need to do a blood gas. The electrolyte analyzers which are separate, measuring only sodium, potassium will be better, Dr. Anand, in that regards. So if there are no further questions, I'd like to thank Dr. Santosh, Dr. Manoj, Dr. Vibha, and Dr. Dhwani for this wonderful presentation. And we will have another interesting session next month. So we will touch base and connect at that point of time. Thank you.